As we grow older, many of us accept spinal stiffness, aching backs, and reduced mobility as unavoidable signs of aging. But what if spinal degeneration isn't simply a matter of wear and tear? What if it's driven by a deeper, more preventable process, one that begins not with bones or discs, but at the cellular level? Increasingly, scientists are pointing to cellular senescence, the accumulation of dysfunctional zombie cells, as a major contributor to age-related spinal decline. And with this insight comes an extraordinary possibility. Early intervention with senolytic therapies might not only treat, but prevent spinal degeneration before it becomes irreversible. The spine, especially the intervertebral discs, is particularly vulnerable to aging. These discs are avascular, meaning they receive little direct blood flow, making it difficult for nutrients to reach them and for waste to be cleared. As we age, cells within the discs, particularly nucleus pulposus and annulus fibrosus cells, begin to experience stress from mechanical strain, oxidative damage, and declining nutrient supply. Over time, many of these cells enter a state of senescence. They stop dividing, stop functioning normally, and start secreting inflammatory molecules, enzymes, and reactive oxygen species as part of the senescence-associated secretory phenotype, SASP. These senescent cells don't just sit idly, they actively disrupt the tissue microenvironment. They degrade collagen and proteoglycans, erode the structural integrity of the disc, promote fibrosis, and attract immune cells that create chronic low-grade inflammation. They even release signaling molecules that sensitize nearby nerves, turning simple movements into painful stimuli. By the time this degeneration becomes visible on MRI or painful to the patient, it has already been silently progressing for years or even decades. This is where early senolytic intervention offers a paradigm shift. Instead of waiting for degeneration to trigger symptoms and then resorting to surgery or chronic medication, we might intervene at the cellular tipping point, eliminating senescent cells before they begin damaging spinal tissues. In animal models, senolytics like dasatinib and quercetin have already shown the ability to clear senescent disc cells, reduce inflammation, and preserve disc height and hydration. Importantly, these interventions worked before severe structural breakdown had occurred, suggesting that the key may lie in acting early, possibly even in middle age, before cellular dysfunction becomes irreversible. What makes this idea so compelling is the possibility of episodic, preventive treatment. Because senescent cells tend to accumulate gradually, a carefully timed senolytic regimen might only need to be administered intermittently, perhaps once or twice a year, to maintain disc health. The use of natural senolytics like Physidin or Ovanillin, which appear to be safe and orally bioavailable, could make long-term preventive strategies even more feasible. Unlike anti-inflammatory drugs, which require continuous use and carry gastrointestinal or cardiovascular risks, senolytics aim to reset tissue homeostasis by removing the root cause of degeneration. Preventive senolytic therapy could also benefit other spinal structures. Facet joints, ligaments, and vertebral end plates all show signs of age-related senescence, contributing to spinal stiffness, misalignment, and nerve impingement. By broadly reducing the senescent cell burden in these areas, senolytics may help preserve overall spinal flexibility, reduce chronic pain risk, and delay the onset of conditions like spinal stenosis or spondylolisthesis. Moreover, because senescence contributes to systemic inflammation or inflammaging, clearing these cells may also reduce risk factors for other musculoskeletal disorders, including sarcopenia, muscle loss, osteoporosis, and frailty. The spine doesn't age in isolation. It ages with the whole body. By improving the health of spinal tissues, senolytics might improve posture, mobility, and even balance, creating a cascade of preventive benefits that enhance quality of life across aging systems. Still, as promising as this vision is, it requires caution and further research. Human trials of senolytics are still in early stages, and no agent has yet been approved for preventive use in otherwise healthy individuals. We don't yet know the optimal dose, frequency, or long-term effects of clearing senescent cells in spinal tissues. And because some senescent cells serve useful functions, such as wound healing and tumor suppression, indiscriminate elimination could carry unintended consequences. The future of preventive senolytic therapy will require precision, identifying the right window of opportunity, the right patient population, and the right molecules. Lifestyle factors may also enhance or diminish the effectiveness of senolytics. Exercise, healthy nutrition, and avoidance of toxins like tobacco or excessive alcohol already help reduce cellular stress and delay senescence. Combining senolytics with these habits could yield synergistic benefits, suggesting a future where spinal aging is not just managed, but actively slowed. In conclusion, the spine's decline with age is not inevitable. It is, in many ways, a cellular disease. By targeting senescent cells before they spark irreversible degeneration, senolytic therapies have the potential to delay or even prevent age-related spinal conditions, preserving function and independence deep into later life. While we're still in the early stages of translating this science into clinical tools, the trajectory is clear. The medicine of tomorrow will not just repair aging spines, it may stop them from aging in the first place.